Hello, everyone. I'm delighted to welcome you to our TULSA-PRO live webinar, The Evolution of Prostate Care and Men's Health at the ALTA Klinik. My name is Matthew Burtnick, product leader for the TULSA-PRO at Profound, and I'm so excited to introduce to you our guest speaker for today, Dr. Agron Lumiani. Dr. Lumiani is a radiologist, founder, and medical director of the ALTA Klinik in Bielefeld, Germany. The ALTA Klinik is the very first TULSA-PRO center worldwide offering the Tulsa Procedure since 2017. Today, Dr. Lumiani is here to discuss his extensive experience as well as his clinical proficiency and efficiency using the flexibility, customizability, and predictability of the TULSA-PRO for a broad set of his patients. Dr. Lumiani speaks many languages, I think about 5 languages in total. However, English is not one of them. As such, on his behalf, Diala Sumun will translate his presentation in English. Diala began the TULSA-PRO journey with Dr. Lumiani and his team as a clinical specialist with Profound. She is currently a PhD candidate at the University of Munich, completing her thesis on the MRI-guided TULSA procedure. Without further ado, I will pass the presentation to Dr. Lumiani and Diala Sumun.
Thank you, Matthew, and thank you, Dr. Lumiani. Dr. Med Agron Lumiani is one of the first radiologists in Germany working intensively with imaging systems as CT and MRI. He is an expert with more than 40 years of experience in this field. He founded the ALTA Klinik in 2007 with the focus on high-quality imaging and innovative procedures and methods by using imaging systems. Dr. Lumiani was also involved with prostate focal therapy in 2009 using the Haifu technology. He can certainly proudly say that the ALTA Klinik is the first TULSA center worldwide performing in March 2017 the first focal prostate treatment for localized prostate cancer with TULSA-PRO. 170,000 newly diagnosed prostate cancers in the US and 60,000 in Germany. Each year, Dr. Lumiani wondered how many of these patients would be suitable for the TULSA therapy. Depending on the grading and risk classification of the tumor, Dr. Lumiani believes that 75% of these patients will benefit from the TULSA therapy, with the largest proportion of patients having low to intermediate risk tumors. We asked Dr. Lumiani the question, why focal therapy? He definitely sees the advantages in organ preservation. The tumor is treated under minimally invasive conditions. Focal therapy should also have the claim to preserve the erectile function by sparing the neurovascular bundle. Also, preservation of the urinary continence by sparing the urinary sphincter muscles. Patients have also the demand to maintain the ejaculation after the focal therapy, which is achieved by sparing the urethra, the vas deferens, and the ejaculatory ducts. All these requirements cannot be ensured during rectal prostatectomy. And then the question was raised for Dr. Lumiani, why then TULSA-PRO? And here are his answers. He was not satisfied with the Haifu therapy. It is a transrectal approach with high risk of thermal damage to the ventral rectal wall. Haifu has, in his opinion, limitations in large prostate glands and in reaching anterior tumors lesion. He was also not convinced that the planning is performed under ultrasound guidance and that during the therapy there is no information and no control over the heat distribution. He also looked into other therapies like IRE, but saw many limitations and decided to go with the TULSA-PRO system. Each TULSA-PRO therapy is individually planned using multiparametric MRI, which ensures accurate visualization of the prostate and localization of the suspicious lesion within the prostate. TULSA brings the flexibility to perform focal therapy in real-time live images with temperature information. With providing multiparametric MRI and a novel technique of his MRI-guided biopsy, TULSA-PRO has completed the concept and the vision of Dr. Lumiani. The ALTA Klinik established itself as a comprehensive center for prostate care management. Dr. Lumiani sees the following advantages of focal therapy using the TULSA-PRO technology. For the patients, these are no damage to the urinary sphincter muscles, no damage to the neurovascular bundles on the opposite side. Urethra and ejaculatory ducts are preserved, no damage to the rectal wall, no blood loss, and short hospital stay. For the physician, on the other hand, he sees the advantages in performing exact planning based on the recent MRI localization, getting precise control and guidance during the therapy through real-time thermometry and contrast-enhanced MRI images immediately after finishing the therapy. And of course, the shorter treatment duration compared to transrectal Haifu by a factor of 4. Looking back on the clinical start of the TULSA program, Dr. Lumiani is convinced that this precise therapy requires the highest concentration and caution during planning in order to spare important function-preserving structures, such as the muscles and the nerves. His team, and especially his MRI technicians, have learned a lot and had to go through a long learning curve to reach today's high level of knowledge and efficiency. Performing general anesthesia in the MR environment also required some efforts. MR-compatible anesthesia equipment had to be purchased. Dr. Lumiani and his team performed 1 to 2 treatments per day at the beginning of the TULSA program. However, with a consistent team and structured processes, the workflow improved to the point that after a short time and to this day, 4 patients are routinely treated per day. In order to become completely independent, Dr. Lumiani has further expanded his clinic to provide 4 patients' rooms with a beautiful living environment for his TULSA patients. During the daily routine, the following processes are considered. The day before TULSA procedure, the anesthesia clearance must be determined. The consultation with the urologist takes place to discuss final urological questions, and then the treatment planning is discussed with the patient. For the patient, it means in detail what results can be expected, which functions will be spared, and which functions might be impacted, depending on the tumor location. At the TULSA treatment day, the MR technician prepare in the morning the system setup and the MR table for all scheduled patients. Then they plan 2 hours per patient treatment and 30 to 45 minutes between the patients. Everything runs according to the same routine. Everyone knows his or her role in the team, and deviations are very rare. It is not a wishful thinking, it is reality. The volume of cases and growth are evidence of this consistent working process and confidence in the TULSA therapy. As you can see here from the case mix, Dr. Lumiani has taken the full advantage of the flexibility of the TULSA system, from focal therapy to BPH to whole gland. Dr. Lumiani established a solid and strong TULSA program, as can be seen with this. With the completion of 2020, Dr. Lumiani has performed a total of 339 cases. And as of today, we are at 380 cases. Just a side note, the COVID-19 restrictions are the reason for the low number of cases in 2020. Many cancellations took place. Otherwise, his case outlook was at 200 cases for the last year. Dr. Lumiani has prepared 2 case studies. This is the first one. We have here a 77 years old man with a Gleason score 7A tumor, ventral in the transition zone. And additional to his cancer, this patient had urination symptoms due to his enlarged prostate. So the planning was performed as a combination of treating the tumor and removing his obstructive prostate tissue by preserving structures that are related to the potency and urinary continence. The images on the first line showing the tumor region in T2 weighted images and ADC diffusion images. This is the black areas. On the top right, we see the tumor in the perfusion images with a bright signal looking for contrast enhancement. In the second line, you see the non-perfused volume, black area, in the T1 images, which indicates to the treated volume after administration of contrast and agent. Looking at the PSA progression, you can see a significant reduction after TULSA therapy. Let's have a look at the second case. We have here a 63 years old man with a Gleason score 7A in the peripheral zone right side. Here you can see the tumor very nicely in the diagnostic images. The red arrows are pointing to it. In the lower image, we see the treated volume immediately after the treatment. You can see here the devices, the TULSA devices. The non-perfused volume black signal here indicates to the treated volume. Also in this case, by looking at the PSA progression, you can see a significant decrease after the TULSA therapy. The first 52 patients treated at ALTA Klinik were retrospective analyzed in a clinical service evaluation. The paper is accepted with minor revision in the online Urologic Oncology Journal. We are waiting for the final acceptance, and we hope we will get it very soon. 80% of the patients received a partial gland ablation, and 46% had a focal cancer treatment plus debulking of their BPH. The majority of patients were discharged the same day or by the following day. The evaluation of the complication rate demonstrates an excellent safety profile. There were no intraprocedural complications, no fistula, no major complications of grade 3B or higher. In total, 2 grade 3A complications were recorded across 12 different patients. The first grade 3A was a mini TURP to remove bladder neck obstruction at 6 months post-TULSA caused by persistent BPH. The second grade 3A patient had a cystoscopy at 1 month due to the high rate of nocturia, 4 times per night. All 37 patients who were previously fully potent 100% at baseline maintained their erectile potency. This evaluation shows that partial ablation had better preservation of urinary continence and erectile function than whole gland and fewer adverse events. On the group seeking BPH treatment, 20 of 24 patients, which is 83%, had improvement at their last follow-up, with reasons providing including reduced rates of nocturia, and discontinuation of either permanent cauterization or BPH medication. The early disease control after initial TULSA, and with that the treatment success rate, is at 88%. 9 patients of total 52 reached their treatment success after a second TULSA treatment. The median PSA nadir was at 1.1 nanogram per milliliter. This paper shows the real-world data and early experience of a clinic that has done everything possible to master this technology in the early phases. It is definitely not the last evaluation of the ALTA Klinik data. We have 70,000 in Germany and 300,000 interventions in the US. required to treat BPH symptoms. These symptoms are known and affect the quality of life to a great degree. Frequent urination and permanent cauterization are stressful and depressing circumstances that patients have to suffer. Most of these patients are suitable for TULSA-PRO. Dr. Lumiani's aim for the BPH patients is performing this non-invasive procedure to eliminate the symptoms, sparing the vas deferens and the ejaculatory ducts in the transition zone. This is how it is looking in the MRI images. Dr. Lumiani's BPH patients are continent after their TULSA therapy and have maintained their potency with ejaculatory function. Now let's have a look at the third case report that Dr. Lumiani has prepared for us. A 62-year-old man with severe BPH symptoms. Prior to TULSA, his urinary frequency was up to 30 times during the day and 10 times during the night. After the TULSA therapy, his urinary frequency during the day and night improved dramatically. The PSA reduction compared to baseline is also significantly. In the following, you see the T2 weighted axial image of the contoured prostate volume in red, and you see the black non-perfused area within the prostate in the perfusion images in the axial and sagittal plane. And this is also a copy of the IPSS questionnaires of this BPH patient before and after TULSA-PRO. A huge improvement in the score from 27 to 0. This is also a short clinical evaluation of the first 6 BPH patients with follow-up data. Very nice is the reduction on the prostate volume side and the improvement of the IPSS and IIEF scores in the questionnaires. In addition to the promising data and treatment results, the intensive and individual care of patients is an important component of Dr. Lumiani's prostate care management concept. Gemada is a well-known and trusted patient forum platform. Here is a feedback from a patient, one of many positive feedbacks from the ALTA Klinik. Unbelievable but true. In most cases, the diagnosis and therapy for prostate problems is done according to old procedures, which are often associated with life-changing side effects. I did not want to undergo these procedures, despite my urologist strongly urging me to undergo these and had already organized the therapy without my consent. I sought and found the solution for my problem in the TULSA-PRO therapy of Dr. Lumiani. With a lot of faith, but with weak knees, I underwent the therapy in November 2018. At no point during or after the therapy did I experience pain. The bladder catheter was removed after 2 weeks. After 6 weeks, all my symptoms from the treatment, such as blood in my urine, were normal again. After 3 months, post-therapy checkup results, everything okay. My libido is unchanged. I'm continent, potent, and can orgasm and ejaculate as before. My PSA 7.3 before, afterward 1.6. My prostate cancer with Gleason score of 7B 4+3 has resolved. My heartfelt thanks to Dr. Lumiani for his great TULSA-PRO therapy and his passionate work with patients. Also thanks to his excellent team who provided me with excellent care. I'm overjoyed. This is a patient feedback after a BPH treatment at ALTA Klinik. What a quality of life. Patient 67 years old. I'm very pleased that Dr. Lumiani has succeeded in developing such an innovative procedure for the volume reduction of a benign and large prostate BPH. For many years, I suffered from having to go to the toilet for 4 or 5 times a night. So deep sleep was hard to imagine. After the operation, I have now regained my quality of life. I can already say 8 weeks after the treatment that everything works as usual. No incontinence, no impotence, no penis dryness, and no retrograde ejaculation. And fortunately, the urge to urinate is gone at night. What a way to live, thanks to Dr. Lumiani and his team. The conclusion from Dr. Lumiani's presentation. ALTA Klinik performed the world's first minimally invasive TULSA-PRO therapy of the prostate in March 2017. Since then, ALTA Klinik has treated over 380 patients with TULSA-PRO. The targeted and controlled application of thermal energy ensures that the diseased tissue plus an additional safety margin can be successively and uniformly ablated while tissue outside the target area remains intact. ALTA Klinik scheduled 2 hours for each TULSA procedure. The first hour is used for preparation and planning, and a minimum of 30 minutes is scheduled between the 2 patients. Dr. Lumiani has also a novel use for TULSA. He uses this technology for patients with chronic recurrent prostatitis, with an excellent outcome reported so far. With these, I have reached the end of Dr. Lumiani's presentation, and I would like to thank you also on his behalf for the attention and interest in this webinar.
Thank you so much, Dr. Lumiani, for your comprehensive and informative presentation. And thank you, Diala, for helping to translate. Very much appreciated. We've been receiving many interesting questions throughout the presentations, which we'll get to. And just as a reminder to all attendees that you can input your questions in writing in the Q&A feature that's at the bottom of your screen. If you just kind of go to the bottom of your screen, there's a button that says Q&A, and you can type in your question there. Our first question relates to the treatment time. And so they're asking, what is the actual treatment time within the MRI facility? And can the patient be prepped outside the MRI and then rolled into the MRI? Or do you do all the patient prep inside the MRI suite?
So die erste Frage, Dr. Lumiani, ist, wie viel Zeit verbringen Sie im MRT-Raum und können für die TULSA-Therapie und können die Patienten auch außerhalb des MRT-Raumes vorbereitet werden?
Also, Sie kennen das, wir sagen, die Vorbereitung des Patienten von der Einleitung zur Narkose bis zum Katheterinfiltration findet vor dem MR-Raum statt und danach der Applikator. Ab dem Moment findet das im MR-Raum und die Zeit, würde ich mal schätzen, draußen haben wir vielleicht 15, 20 Minuten. Der Rest ist das heißt 1 Stunde 30, circa 1 Stunde 40, je nachdem, ist das der Patient im MR-Raum.
Yeah, so the patient anesthesia preparation is outside the MRI suite, and this takes around about 15 minutes with inserting the catheter as well. And then the patient will move to the MRI suite, and from there, Dr. Lumiani is counting per patient around about 1.5 hours. So in total, he is counting 2 hours per patient.
Wir haben natürlich die Vorbereitung hat schon vorher stattgefunden, einen Tag zuvor.
Yeah. So the patient preparation will be outside the MRI suite, and of course, all the discussion with the patient will take place 1 day before the treatment.
Okay, very interesting. And so once the patient has completed the TULSA procedure, the next question relates to how quickly will the patients be back to their normal routine? What is the post-procedure catheter process like?
Die Frage ist, wenn die Therapie vorbei ist, wie lange braucht der Patient, bis er sich erholt hat,
Ja.
und wie lange ist die Katheterzeit?
Ja, also nach der Therapie bleibt der Patient und wird überwacht von der Krankenschwester bei circa 1 Stunde plus minus, eine ein bisschen früher, andere spät. Und nach 1 Stunde Überwachung geht der Patient auf Station.
Okay.
Das ist die erste Antwort.
Ja.
Oder die zweite gleich.
Genau.
Sag mal lieber das.
Genau.
Können Sie das übersenden?
Genau. So immediately after the therapy, the patient will get into the recovery room for half an hour to 1 hour. So depending on the patients, but they leave them for 1 hour in the recovery room, and then they will move the patient then to the patient room or station where the recovery or the patient will stay overnight in the clinic. Yes.
Die Katheterfrage, wie lange der Patient den Katheter trägt, haben wir mehrere Kriterien. Das erste ist Prostatagröße, Restvolumen der Harnblase nach Miktion. Wie lange haben wir behandelt? Wie lange haben wir Wärme übertragen? Das sind die Hauptkriterien. Und zum Schluss, der Patient muss Resturin messen. Das sagen wir, wenn wir sagen so circa plus minus 4 Wochen. Er muss aber Resturin messen, 3 Tage lang. 3 Tage hintereinander, wenn unter 100 Milliliter, dann kann der Katheter raus. Sonst muss man eine Woche später den Test machen.
Mir sind jetzt einige Faktoren. Okay.
Genau, also das erste ist Prostatagröße, Restvolumen der Harnblase und wie lange wird behandelt.
Okay, so the question to the catheterization time. So we have several factors. So the first factor would be how long we have treated, and the prostate size as well. So how many prostate or how many tissue have we treated during the TULSA therapy?
Weil wir eben den Tumor und die Vergrößerung mitmachen.
Yeah, because he is combining always TULSA cancer treatment with BPH treatment as well. And the third factor will be the
Resturin in der Harnblase.
Yes. So the how many of urine is still in the bladder? So
vor der Therapie. Ne?
Before the therapy itself, and so these are the factors, and in total, wie lange lassen Sie?
Und also wir sind plus minus 4 Wochen, wenn Resturin 3 Tage hintereinander unter 100 Milliliter.
So if the urine in the bladder would be below 100 milliliter, then he would remove then the catheter.
3 Tage hintereinander muss er passieren lassen.
3 days in row, he would then remove the catheter.
And so that's an interesting point, that the size, the prostate volume, and how much you are ablating become important decisions on the management of the catheter. Can you give us a bit of a sense of timing? So if you do a whole gland ablation versus a pure targeted or focal ablation, what does the difference in catheterization look like?
Wenn Sie quasi Hochgland im Vergleich zu fokale Therapie, was würden Sie sagen, wie die Zeiten der Katheterisierung ist? Also Hochgland lassen Sie vielleicht länger den Katheter, oder wie würden Sie das sehen?
Genau, je mehr Gewebe wir behandeln und je länger, automatisch, wenn Sie mehr Gewebe behandeln, behandeln Sie auch mehr. Also die Behandlungsdauer oder Zeit ist auch länger. Und das beeinflusst auch, wann der Patient den Katheter.
Yeah, so he says also that during the focal therapy or targeted therapy, the volume of the prostate, the ablated volume, is not so high. So the catheterization time would be shorter than if you treat a lot of tissue, somehow 80 milliliter of prostate. The patient needs more time to recover, or the urethra needs more time to recover. So you will leave the catheter longer. But so if after evaluation of the data, it is between 1 to 4 weeks in total, depending on prostate size, ablated volume, and the urine volume in the bladder.
Interesting. We have another question here. How effective, in your experience, is the TULSA procedure for prostate cancer lesions that abut the prostate capsule? So the lesions that are abutting the prostate capsule, often you can see that on an MRI where the cancer is abutting the prostate capsule and may have a certain amount of capsular contact. How do you manage those patients?
Die Frage ist hier wegen Prostatakarzinome, die quasi bis
Kapsel
zu
infiltriert haben. Ne?
Genau, genau. Wie sehen Sie die Effektivness?
Ja.
Die
Also primär, wenn ein Tumor die Kapsel durchbrochen hat,
Ja.
dann ist er nicht mehr lokal begrenzt,
Ja.
heißt dann auch nicht primär geeignet für die Tulsa-Therapie.
So to the first part, if the tumor infiltrate the capsule itself, it is no more a localized tumor. So then he would not treat this
Primär.
Primary with TULSA. Yeah.
Aber es gibt,
But there is a but.
Ja, aber wenn ein Patient zum Beispiel 80 Jahre alt ist,
Ja.
dann operieren die Leute nicht mehr. Dann bleibt für den Patienten die einzige Möglichkeit, Lokalbehandlung bleibt die Bestrahlung.
Ja.
So, und dann sage ich, statt Bestrahlung, dann ist die Tulsa die bessere Methode. Deswegen sage ich primär nicht, aber sekundär schon.
Yeah. So in
Wenn der Patient nicht operiert und so weiter. Ne?
Yeah.
So.
In a secondary point of view, if we have an 80 years old patient and he is not suitable for surgery and instead of surgery and he has
Weil die Urologen über 80 operieren nicht.
Ja.
Also die werden alle inkontinent.
Yeah, so he says also that the urologists are not really doing any surgery for patients over 80 years. So that's why this patient would get radiotherapy, and instead of having all the side effects of radiotherapy, he would do the TULSA treatment for these patients in order to treat the tumor locally, but it's more suitable and more favorable from the adverse events. So that's why he would secondary then select TULSA for these patients.
Ich habe vielleicht als Beispiel, ich habe einen aus Berlin Patienten über 80 Jahre, er hat vor 10 Jahren Radiotherapie bekommen, weil anscheinend nicht operabel. Und jetzt, nach 10 Jahren, hat er ein dickes Rezidiv. Und dann nach Radiotherapie kann man sowieso nicht nochmal Radiotherapie, nicht operieren. Dann haben wir behandelt. Und PSA 3 Monate später, kam vor 2 Wochen. PSA von 12 auf 0,22. Patient glücklich.
Ja, Sie müssen mir jetzt helfen, diese Daten.
Ja, gut.
Wie alt ist der Patient?
83.
Okay.
Aber er hat vor 10 Jahren Radiotherapie bekommen. Und jetzt Rezidiv, dickes Rezidiv.
Yeah, so he is telling me about the patient, 83 years old from Berlin. He came after tumor recurrence after 10 years of radiotherapy. And this patient is not more suitable for surgery, and he had a big recurrent tumor. So the decision was very easy for Dr. Lumiani. He treated him with TULSA, and his PSA value from
12 auf 0,2.
So from 12 point something degrees to 0.3. So a very successful treatment for this patient.
Und MRI tumor frei.
Yeah, and
MRI control.
The MR imaging follow-up after 3 months is clean, negative.
Yeah.
So this patient has a big benefit from TULSA because he is not suitable for surgery, not suitable for radiotherapy. So this was the only option for him.
Komplikationslos.
And without any complication after that. Yes, the patient is very happy. So it's just a recent patient from Berlin.
Perfect. And so let me kind of rephrase maybe the same question. Let's say it's a patient and it's clearly localized prostate cancer, but the tumor is not through the capsule, but abuts the capsule, meaning it sort of touching the capsule.
Yeah.
Or how effective is TULSA-PRO for those patients?
Wie effektiv ist die TULSA-Therapie für Tumore, die wirklich an der Kapsel oder die Kapsel berühren?
Wenn die Prostata nicht groß ist, es hängt immer auf den Radius, wenn unter maximal 3 Zentimeter, haben wir gar keine Probleme, die Tumor zu behandeln. Was problematisch ist, wenn Samenblasen infiltriert sind, dann machen wir diese Leute, sagen wir lieber die Operation oder andere bei Samenblasen. Bei Kapselinfiltration haben wir wenig Probleme, wenn die Prostata klein ist.
Yeah. Okay. So he doesn't have any concerns to offer TULSA-PRO therapy for patients with tumor at the capsule or hitting the capsule as well, because he said if it's in the treatment volume, I'm okay to do that. But if the tumor is exceeded or in the seminal vesicles, he would then tell the patient that he is not suitable for TULSA, and he would move him to surgery. But he has no concerns to treat these patients.
Okay, so if I understand correctly, when Dr. Lumiani obviously does very high quality MRI staging, if the tumor characteristics are consistent with a localized prostate cancer to the prostate, there is no concern whether the tumor is abutting the capsule or whatnot. There's no concern. The concern starts to grow when the tumor has gone beyond the prostate capsule, maybe in the seminal vesicles, etc.
Yes.
Okay.
Exactly.
Okay, so we kind of talked about some of these patients. There's another question about almost the opposite question. Who is the ideal candidate for TULSA-PRO, in your opinion? So who, Gleason score, stage, age, what does the ideal patient look like for TULSA-PRO?
Wer ist der ideale TULSA-PRO-Kandidat für Sie? Also wenn Sie jetzt Gleason Score, Staging und Tumorlokalisation und so weiter. Wer ist der ideale?
Ja. Der ideale Patient ist, der ein Gleason 6 bis 7a hat, ventral der Tumor liegt und weit vom Schließmuskel ist. Also ventral in der Mitte der Prostata, nicht oben, nicht unten. Ja. Das ist der ideale Patient.
So the ideal patient or candidate for TULSA-PRO would be a patient with a Gleason score 6 and 7A. And his tumor would localize in the ventral plane, far away from the sphincter. So this patient would 100% preserve all the functionality. So this is the ideal patient, yeah. And of course, if he is also very young, so he would benefit a lot from this therapy, yes.
Interesting. And what are the ranges of prostate volumes that you treat at the Alta Klinik? Like what, is it small prostates, large prostate? It actually sounds like it's a variety.
Ja, die Frage ist hier, wie groß sind die Prostate, die Sie behandelt haben? Welche Reichweite von wann?
Also wir haben also bis 180 Milliliter ist für uns gar kein Problem, wenn die Länge kraniokaudal 5 Zentimeter ist. Aber erst können Sie,
So,
bei BPH zum Beispiel.
Aber selbst dann können Sie den Applikator
das kommt noch,
So up to 180 milliliter is no problem with with TULSA-PRO.
Genau.
So if the sagittal line or size, the sagittal size of the prostate is 2-5 centimeter, but there is no problem. He can move the applicator and do it in a second session as well.
Wir haben einen Patienten aus USA behandelt mit einem Prostatavolumen von 320 Milliliter. Er hatte aber wirklich 10 Zentimeter kraniokaudal. Ich habe gesagt, er muss doppelt bezahlen, sonst zweimal. Hat auch funktioniert. Ist wirklich so,
So he is telling us about a patient from the US who had 320 milliliter of prostate size, and he was treated in 2 sessions. But removing all his prostate tissue was a big challenge, but he doable with TULSA. He doesn't have any concerns about this. And at the same time, he said these patients are preserving all their functionalities, potency and continence as well.
Wow. And so was that a successful trip? So this patient had a 300 gram prostate. You did 2 treatment sessions. How were the outcomes in that patient?
Welches Ergebnis hatte dieser Patient am Ende?
Er war glücklich, wollte gar nicht mehr zur Kontrolle, ich wollte nochmal die Kontrolle machen, der ist dann gleich im Flugzeug wieder zurückgefahren. Also das war gut, aber ich wollte es nochmal tun.
In der Größe der Prostata, wie viel haben Sie reduzieren können? Vom Volumen her, können Sie sich dran erinnern?
Nochmal, er ist gegangen, ist nicht mehr gekommen.
Okay. He said that the patient was so happy afterwards that he is still in contact with him, but he didn't come back for follow-up, so he can't really say how much we have ablated, but he always saying, I'm so happy. So he didn't come back for follow-up, but it was, in his opinion, a very successful treatment.
Wir wissen aber, bei großen Volumina als Problem, also ist nicht die Behandlung als solche, wir wissen, bei großen Volumina Bei manchen Patienten haben wir Resorptionsstörungen, wird nicht abgebaut, das Gewebe. Dann kriegen die Leute häufig Infektionen, Nebenhodenentzündungen und so weiter. Das ist dann, das ist das. Also wenn nicht zu viel Volumen, also behandeln können wir große Volumina, nur große Volumina erwarten wir bei
Oder
manchen
Sie machen
auch.
es in 2 Sitzungen.
Nee, das machen wir, können wir nur ablesen. Aber dann, je größer das Volumen, desto erwarten wir, dass es Resorptionsstörungen gibt und Infektionen. Das wissen wir. Und wenn der Fall eintritt, dann müssen wir tot machen. Dann ist der Patient befreit. Oder lange behandeln, geht es auch.
So it's he's talking about very, very large prostate volume. So thermal ablation or thermal therapy is doable, but it's also, it has a lot of, let's say, not complication, but this ablated volume or this necrotic volume needs long time to be absorbed by the body. So that's why these patients would have still some problems in urination, but so then he would advise, or he would advise the patient to do a TURP to remove this necrotic tissue, but otherwise he is using antibiotica for this patient in order to solve the infection, if they have infection in absorbing the necrotic tissue.
Die Therapie als solches ist keine Limitation, aber die Nebenwirkungen, das ist das, was
so the therapy itself, there is no limitation in treating a very large prostate volume. It's more about the necrotic tissue that is then inside the body, and some patients have like from nature problems to observe this necrotic tissue, and sometimes they come back with urinary infection.
Über 100 milliliter.
Yeah, we are talking, he said, here we are talking about prostates above 115 milliliter. Yeah.
Very interesting. So the next question is a bit more technical than maybe clinical, but the question relates to, can you define the precise difference between TULSA and Haifu?
Die Frage ist hier, was ist wirklich präzise erklärt, was ist der Unterschied zwischen Haifu und TULSA-Therapie?
Genau.
Von der technischen Seite.
Ja, genau. Das allererste ist, dass wir fangen mit Haifu.
Ja.
Das allererste ist, dass der Haifu hat einen transrektalen Zugang.
Yeah. So
wir strahlen Wärme durch Rektum in die Prostata.
Yeah. The first point is on the Haifu side, the source is sitting in the rectum, and we are giving energy through the rectal wall. This is the first one. Disadvantage, you see that.
Das bedeutet, die Wärme geht durch die ventrale Rektumwand und wir haben immer Schaden an der Rektumwand. Ein Schaden, was klinisch nicht sichtbar ist, ist aber immer da.
Okay.
Deswegen beim Rezidiv, beim zweiten Mal macht keiner Haifu, weil man weiß, macht eine Fistel. Das heißt, ich habe immer Rektumschaden.
Yeah. So he said that with the Haifu therapy, he has always, with all the patients that he have treated, rectal damage, not clinically visible, but that was the reason why he was not repeating Haifu for a second time, because otherwise he can be sure say for 100% that they will have a fistula afterwards. So Haifu therapy is just doable just for one session, and a second session will be associated with fistula.
Ja. Die Haifu-Therapie ist eine punktuelle Therapie, punktförmige Therapie. Deswegen dauert nach unserer Erfahrung viermal länger mit Faktor 4 als mit Haifu oder TULSA. Oder TULSA ist 4-mal schneller als Haifu.
So the TULSA therapy is four times quicker, faster than the Haifu therapy, the ablation time. We are talking about the ablation time because we have with Haifu a focused, and with TULSA, as I know, it's a directional wave profile. So that's why it takes much longer with Haifu to treat a small tumor, right? Yeah.
Das heißt, wenn wir eine große Prostata mit TULSA 1 Stunde brauchen, mit Haifu hätten wir mindestens 4 Stunden.
So,
reine Therapie.
If we are talking about just the ablation time, if TULSA takes 1 hour to ablate the whole prostate, Haifu would take 4 or 5 hours to ablate. This is the second.
Das nächste ist, die Haifu-Therapie wird mit Ultraschall geplant, ohne dass man den Tumor sieht. Und während der Therapie gibt es keine Kontrolle. Während und nach der Therapie gibt es keine Kontrolle, ob die Wärme überall angekommen ist,
Ja.
haben wir Regionen, was weniger geblieben sind. Das haben wir bei
So he sees a limitation also in the planning phase. It's under ultrasound guidance. He has a lot of issues. He couldn't see the tumor, and during the therapy itself, he couldn't see any feedback from the system about temperature or precision, how much he has treated, and what else?
Nur wenn Sie MRT-Kontrolle machen, erst dann wissen Sie.
Okay, he sees the big benefit in the MRI guidance and imaging and real-time precision in the real-time of the therapy.
So, und jetzt im Gegensatz zu der TULSA ist transurethral.
Yeah, so TULSA is transurethral.
Das heißt, wir beschädigen den Rektumwand nicht.
So we are not damaging the rectal wall.
Er weiß besser als es gibt 10 Elemente, wo wir je nach Größe der Prostate, jedes Element für sich können wir markieren, demarkieren, angrenzen.
So, we have 10 independent elements within the prostate which we can select and deselect, plan or not plan. So we are very flexible in the planning.
Während der Therapie haben wir die Thermometrie und dann die Temperaturdosis.
So during the therapy itself, he has the temperature feedback and the dose, the thermal dose.
Und zum Schluss haben wir mit MR immer noch die Kontrolle des Ergebnisses.
So immediately after, and then immediately after the therapy, he has always the confirmation about what he has treated.
Wir haben keine Schaden an den benachbarten Organen, weder an Rektum noch an der Harnblase.
Bisher, I'm sorry. So far, he didn't see any damage in all the patient, in any damage at the rectum or on the neighbor structures or sphincter or muscles. He never see that after TULSA therapy.
Okay, very interesting. And so along the same lines is another question. Have you had any issues with urethra damage from the TULSA procedure? Also, there's a cooling balloon that goes in the rectum. Have you had any issues with any rectal fistula? So I guess you already answered, you've seen no issues at all, not just a fistula, but even any issue with the rectum. But have you had issues with the urethra due to the TULSA device?
Ja, haben Sie bisher irgendwelche Schäden an der Urethra gesehen durch die TULSA-Therapie oder noch nicht?
Wir haben bis jetzt keinen Schaden gesehen. Wenn, dann waren Patienten, die vorher schon einen Schaden hatten nach voriger Intervention, aber nicht von uns.
So the damage at the urethra were never caused by the TULSA therapy. If patient had the damage, it was before the TULSA.
Und da hat der Professor Musa das auch erwähnt.
So if there were any problems with the urethra, so that these were not caused by the TULSA therapy itself. Because the urethra is cooled all the time and the rectum is cooled, so he has never seen any damages at the urethra.
Was bei Haifu eigentlich häufig vorkommt. Die Strikturen.
So he says these restrictions are more. He has seen this more in the Haifu therapies instead of TULSA. So no really damages.
Interesting. You mentioned a bit earlier, Dr. Lumiani, that retreatment with some other technologies were difficult, but in your more recent evaluation of your TULSA data, you mentioned retreating patients with the TULSA procedure. And so from a retreatment perspective, how do patients tolerate a second TULSA procedure? And have the cancer control outcomes improved in those men receiving a second TULSA procedure?
Ja, wir reden hier, oder die Frage geht um die zweite TULSA. Nach Rezidiv. Wie tolerieren diese Patienten die zweite TULSA und wie sind die Ergebnisse, die onkologischen Ergebnisse danach?
Also generell, wir sehen, die Patienten tolerieren das komplikations- oder ohne Probleme die zweite TULSA-Therapie. Der Erfolg der zweiten TULSA-Therapie, sonst würden wir es nicht machen, ist deswegen gut, weil nach der ersten Therapie ist Prostata schon geschrumpft, ist klein. Und deswegen haben wir auch gute Ergebnisse. Sonst würden wir den Patienten nicht zumuten, nochmal das Gleiche zu machen, würden wir ihn auch zum OP zu schicken, aber das ist überhaupt kein Problem, weil eben die Prostata ist kleiner geworden und durch diesen Methode bedingt, wir sehen keine Nachteile.
So these patients are really tolerating the TULSA therapy very well. without any complications.
Yep.
And the second point is that because after a first TULSA, the prostate gland itself is shrinks and it's very small. So he would say he has 100% clinical or oncological control after the second TULSA for these patients.
Oh, interesting. So that when you treat the same patient a second time, because the prostate volume has reduced,
Yeah.
the second procedure is pretty effective at that point because it's easy. Interesting. So speaking about sort of the retrospective analysis that I think we're all excited about, seeing published very soon, there's a question here. Have you ever thought about planning a prospective study and maybe even comparing a few different focal procedures or comparing with active surveillance?
Ja, eine Frage ist, die Daten, die Sie eventuell in Zukunft dann publizieren möchten, haben Sie mal überlegt, ob Sie die fokale Therapie vergleichen zu den Patienten, die in aktive Überwachung gehen? Haben Sie da Daten? Wie würden Sie das, haben Sie darüber nachgedacht, dass Patienten, die eine fokale Therapie haben, profitieren von der Therapie im Vergleich?
Also der klassische Patient ist zum Beispiel ein Patient, der einen 7a-Tumor hat, aber der Tumor befindet sich apikal und Prostata liegt so ungünstig, dass wir ihn inkontinent machen. Dann sagen wir, diese Patienten sollen eigentlich operiert werden. Aber der Operateur sagt, wenn ich operiere, der wird inkontinent. Dann sagen wir, solche Fälle können wir Active Surveillance machen. Und bei älteren Leuten, wenn PSA nicht steigt, Tumor nicht größer wird.
Ja, die Frage ist, ob Sie da eine Studie planen, diese Patienten, die in Überwachung sind, zu vergleichen mit den...
Wir werden sicherlich in Zukunft mit unserem Urologen, aber wir haben noch einen jungen Kollegen und anderen Leuten gerne solche, weil wir haben alle Daten, wissen Sie ja selber, wir haben alle Daten von Urologen, von MRT, von Pathologen, wir haben alles hier. Höchstwahrscheinlich werden wir es machen, nicht nur eine, wir werden bestimmt auch mehrere Themen behandeln. Wir haben auch bewusst mal gewartet, dass es ein bisschen Zeit geht.
So he is planning to do a lot of publication or analysis because he has a lot of data and a lot of follow-up data as well. So he was not thinking to compare active surveillance with focal patients, treatment patients, but he will think about this, But he has a lot of data to analyze. So he has a lot of BPH patients, also focal therapies,
Also für uns ist die Tulsa-Therapie wirklich eine wunderbare Brücke. Die meisten Patienten, die eine Active Surveillance empfohlen wird, diese Leute über die Zeit lassen sich trotzdem behandeln, egal mit welcher Methode. Und deswegen ist die Tulsa eine wunderbare Alternative für diese Leute, weil die aus Angst entweder lassen sie operieren oder anderswo machen, aber das wissen die auch in Active Surveillance Gruppe. Viele Leute springen ab.
He says most of these active surveillance patients are coming to have the focal therapy or the organ preserved therapy with TULSA because these patients are afraid to live with the tumor and have concerns to live with this cancer. That's why the most of them are really active surveillance patients here.
So that's an interesting answer because there's actually another question here. We have a couple more questions here to go. We're almost done. So when we talked about the ideal TULSA candidate, we talked about a Gleason 6 patient or a 7A patient. So the question here refers to many patients with Gleason 6 or 7A are actually on active surveillance, and we follow them with PSA. So is that something that Dr. Lumiani does as well, follow patients on active surveillance? And then what is the factor that switches them from active surveillance to the TULSA procedure?
Die Frage ist, viele Patienten, die Gleason Score 6 und 7 haben, sind Active Surveillance oder aktive Überwachungspatienten. Wie sehen Sie da den Anteil, die Sie dann mit TULSA therapieren? Kommen Sie hierher, weil Sie nicht mehr in Active Surveillance leben wollen?
Also Wir basieren uns eine Information der Studie von Professor Sauter, dem Pathologen, und laut Professor Sauter bei 7a-Tumoren, wenn die Viereranteile die Viereranteile bis 20% ist und PSA niedrig ist, dann ist dieser Tumor ähnelt dem Lesion 6. Auch von der Prognose. Ist ein 7a-Tumor mit Viereranteile über 20%, also 30, 40, 45, dann er ist nicht vergleichbar mit Lesion 6. Aus unserer Sicht, er braucht dann Behandlung und ist nicht geeignet für Active Surveillance.
So he is looking, when a patient in active surveillance is coming to his clinic and he is looking at the PSA, at the Gleason score. So patient with Gleason score 7, 3 plus 4, and the 4 pattern is below 20%, then he would say, okay, he would treat this patient as Gleason score 6 patient, and he will say, leave in active surveillance. Otherwise, if the fourth pattern is higher than 20%, then he would say it's an aggressive tumor and he should get the treatment. So he's looking at the pattern 4 for his decision. And of course, in combination with the PSA value as well.
Very interesting. Okay, so the last question, and this is actually a question for me. So your initial evaluation looked at your patients from the beginning of your program, from 2017 to 2018. Do you think the outcomes are continuing to improve as you get more experience with the device, or do you think the outcomes are consistent?
Yeah. Über das Paper, was wir veröffentlicht haben. Sehen Sie im Vergleich jetzt von heute eine Verbesserung in den Ergebnissen als zu dem, was publiziert worden ist?
Ja, auf jeden Fall.
Aufgrund der Erfahrung?
Auf jeden Fall.
Definitely. You see definitely an improvement.
Ja, wir wissen mittlerweile, dass die Prostatagröße, Radius über 3 cm ein Nachteil. Eine Rezidivquote steigt, ist er niedriger nicht, das wissen wir. Wir wissen aber auch, dass auch bei kleiner Prostate, bei manchen Patienten ist die Wärmeverteilung so nicht gut, dass wir dann immer an der Stelle 2-mal, wenn es sein muss, wo der Tumor ist, auch 3-mal wiederholen, damit wir...
Also das heißt, Sie wollen einfach Ihre Rezidivrate reduzieren auf 0 und deswegen selektieren Sie die Patienten.
Das Zweite ist, wissen Sie auch selber, wir haben angefangen, vorher die Prostata zu verkleinern, mit TURP. Das wollen wir jetzt mit Holmium machen. Auch das sind so wichtige Schritte, die wir unternehmen müssen, um das Ergebnis zu verbessern.
So at the beginning, so he says that his patient selection is much preciser than before, because he is looking now really at the prostate volume and the radius from the applicator to the edge of the prostate. So that's why he is selecting his patients in another way. And addition to that, he says if the prostate size is very high, it's still a TULSA candidate, but he would, before treating the patient with TULSA, he would just reduce the volume of the benign volume of the prostate, and using this with TURP or laser. But in his opinion, it's the prostate volume, the most the reason for the recurrence recurrence tumor during the first phase in his clinic.
Und dort, wie gesagt, wo wir sehen, dass die Temperatur nicht erreicht, wir wiederholen aber nur an der Stelle, nicht die ganze Prostata. 2-mal, im Extremfall und 3-mal.
Yeah, and he says also with TULSA, he has the flexibility to repeat the ablation zone again a second time to be ensured that these tumors are treated afterwards. So
ganz am Anfang aber nicht gemacht.
Yeah, at the beginning of his program, he didn't do a second sweep over the tumor region. So that is also a learning point, or learning during the learning curve. He learned to treat the tumor region or ablate the tumor region a second time during the same session, of course.
Okay, fantastic. There's just one last question here, maybe very quickly because we're running out of time. Have you ever treated a patient with TULSA who didn't have a rectum at all?
Haben Sie bisher einen Patienten behandelt, der kein Rektum hatte?
Ja.
Yeah, I think I can remember
it's
one
fine,
patient,
it's fine, yeah.
two patients.
Ja.
Yes, two patients.
Okay.
We had treated two patients.
Ja, weil wir haben gefragt, was machen wir mit den
Rectum,
Rektum,
yeah.
Kühlung, da haben wir daneben gelegt.
Okay,
Ging's
yes,
auch.
yes. So the rectal device, which is inserted into the rectum, was outside the body, of course. But yes, he had
Weil die
treated.
können mit Haifu sowieso nicht. Ne?
And they don't have any possibility to treated with
Haifu.
Haifu. So it was these patients are also benefits from the therapy.
Okay, well, thank you very much. We're out of time, but thank you very much. Dankeschön, Dr. Lumiani. We really appreciate your time. We really appreciate your perspective on using the TULSA procedure. We're very much looking forward to seeing the publication come out, and of course, all the excellent work that you continue to do. So thank you very much. Have a good evening.
Thank you.
Yeah, thank you. So.
Bye-bye.
Bye-bye. Ciao.
Bye, thank you.
Ja.